pleasure to invite Dr. Tina George, Professor of General Medicine and Clinical Epidemiology Unit, who will be moderating the session, and Dr. Joseph Liyaskar, Assistant Professor, Department of Medicine, will be will be doing the presentation, and I'll hand over to Dr. Tina and Dr. Joseph.
Thanks for inviting me, Vignesh. I think Joseph will be taking us through the Great Cerqual. It's more of a kind of a starter for everybody who's interested in systematic reviews of qualitative studies. We've chosen a paper, but the talk is predominantly to give us all a sort of a framework to follow and teach us what this Great Cerqual is all about. Over to you, Joseph.
Thank you, sir, and thank you, ma'am. In today's presentation, we'll be seeing how to use the Great Cerqual checklist to assess our confidence of findings in a qualitative systematic review. So before we go into the Great Cerqual checklist, I would like to give a brief overview about the synopsis of my study. First, in the beginning, we'll be seeing what is qualitative research, and we'll be seeing how is qualitative research different from quantitative research, and what are the steps involved in formulation of a qualitative evidence synthesis. We'll be coming across a case scenario, and in the end, we'll be applying the Great Cerqual checklist to critically appraise a qualitative systematic review. So first, before going into the presentation per se, I'd like to put across three different scenarios. Scenario one is in a hospital where we notice patients get delay and they are poorly compliant to antihypertensives, and you would like to assess the patient's beliefs, fears, and barriers to take antihypertensive medications. And scenario two is an obesity prevalence study wherein we are attempting to determine the prevalence of obesity among college students and find its association with diet, physical activity, and screen time. And scenario three is a smoking cessation program, and it's a new program which shows variable success. And you would like to assess the quit rates and understand why some participants fail or succeed in quitting smoking. So I'd like to put across a question to the participants of this session as to which of these scenarios would you prefer to do a qualitative study, and in which of these scenarios would you be preferring to do a quantitative study, or would you use a mixed methods model? Any other options from the audience? So most of us seem to be agreeing with this thing. In scenario one, our main aim is to find out the patient's perceptions about antihypertensive medication and why exactly they're not taking the antihypertensive medications. And the ideal study design here would be a qualitative study. Whereas in the second scenario, we are planning to assess the prevalence of obesity and see its association with multiple lifestyle factors. And so the ideal research approach will be a quantitative study. And whereas the third thing, we are doing quantitative as well as qualitative analysis, which is quit rates and seeing why participants fail or succeed in the program. And here we'll be using a mixed method model where we'll be doing both qualitative and quantitative analysis. So what is qualitative research? Qualitative research is a method used to gain deep understanding of a phenomenon, and it is often used in healthcare and educational settings. And here our aim is to find out in depth about a particular hypothesis, and the outcome here is not in terms of numbers or statistical values, but in terms of the patient's perspectives per se. Here we find out data not by close-ended strict questions, but rather by using open-ended questions, and the data can be collected in the form of interviews, observation, or in terms of focus groups. And what do we do with this data? We aim to, most of the times, qualitative studies done to generate a new hypothesis rather than to test a new hypothesis. So how is qualitative research different from quantitative research? In qualitative research, our main focus is to explore new ideas and generate new hypotheses, whereas in quantitative research, our main aim is to test a pre-existing hypothesis. And in qualitative research, we analyze the data by summarizing and categorizing into multiple different themes, whereas in quantitative research, we utilize multiple mathematical and statistical analysis to make a finding. The qualitative research is usually expressed in words and statements from the individual participants, whereas in quantitative research, the data is provided in terms of numbers, graphs, and tables. Usually, qualitative research utilizes only a small number of participants, whereas in quantitative research, we use many large sample size. The questions are usually open-ended in qualitative research, whereas in quantitative research, it's usually close-ended. And qualitative research is has a high subjectivity, whereas quantitative research is more objective in nature. And if we have to do a qualitative evidence synthesis, what are the steps in designing a qualitative evidence synthesis. For this, I'll be using the WHO's framework for qualitative evidence synthesis published in 2021. The steps in formulating a qualitative evidence synthesis involves first step would be to question a formulation. The second step would be to search appropriate literature to identify the pre-existing systematic reviews on the same topic and identifying other primary studies that can be included in our systematic review. Third step would be to critically appraise the individual studies included in the systematic review. Step 4 would be to extract data from each of these individual studies included in the systematic review and make our own synthesis from this individual studies. And step 5 would be reporting the synthesis in terms of established standards. So how do you formulate a research question? For this, we use something called as a SPICE protocol. In quantitative studies, we all know about this Picot statement and all this, but in qualitative research, we use something called as a SPICE protocol, where S stands for the setting in which the intervention is planned to be done or the policy is planned to be implemented. P is the population or the stakeholders who will be directly affected by the results of the study. And I stands for the phenomenon of interest that we are planning to assess. Comparators may or may not be there in this qualitative study, and evaluation includes determining outcomes, whether they are relevant, appropriate, and acceptable. So, for example, if we are planning to, our research question is what are the perceptions and beliefs of adults with cardiovascular disease regarding lifestyle behaviors and their impact on vascular health? What will be our SPICE protocol that we'll be using? Our setting here would be a community setting or in the hospital setting. Our population would we'll be choosing adults who are diagnosed with cardiovascular disease. Our phenomenon of interest here would be perception and beliefs and attitudes about the participants towards lifestyle behaviors. Here we'll not be having any comparison group, and evaluation will involve assessing the impact of behaviors on vascular health. So another approach that we can use to formulate the research question is the spider approach, where S stands for sample, PI stands for phenomenon of interest, D is for the study design, E is for evaluation, and R is for the research type. So the next step would be to search the existing literature to find out any pre-existing qualitative evidence synthesis which is available on the same topic, and finding out what is the gaps that we have in the evidence that we are aiming to fill from our new qualitative evidence synthesis. So for this, we can use multiple databases, which include the PubMed database, or we can use the Embase, and we can use multiple mesh terms to find out appropriate qualitative evidence synthesis on a particular topic of interest. So here, what is different from quantitative research studies is that in qualitative research studies, many of them do not have clear-cut terms to identify them as qualitative evidence synthesis, and we might have to use multiple different terminology to assess to find out appropriate qualitative studies on a particular topic of interest. So multiple challenges exist in identifying qualitative studies, which include facts that many of them do not have meaningful titles. Many of them are of poor quality and do not have a structured abstract. They have superficial depth of indexing, and many of the studies do not have detailed description of the qualitative methods they have used. So these are all some examples of databases from where we can retrieve qualitative research. Examples include the CINAHL database, Embase, Medline, and PsycInfo for finding important qualitative studies towards our qualitative evidence synthesis. So other sources that we can look up to find evidence primary studies for a qualitative evidence synthesis include hand searching, backward citation, and forward citation. We can also search in grade literature like Google Scholar and published thesis. We can also look at complementary sources like program reports, thesis, and book chapters. So the fourth step would be to critically appraise the literature. Here, there is no gold standard instrument that is being recommended to critically appraise the literature, and there are multiple different tools which we can use to critically appraise each of the individual primary studies which we use in the qualitative evidence synthesis. So two of the examples that we can use to appraise each of the individual qualitative studies include the CAMLOT tool, which is nothing but the Cochrane Qualitative Methodological Limitations tool, and second is the CASP checklist for qualitative research. I'll be coming to the details of the CAMLOT tool in the coming slides. And step 4 also requires us to extract data from each of these individual primary studies and synthesize our own finding to form a qualitative evidence synthesis. So the data extraction, while we assess each of these individual primary studies, we'll be coming across first order data and second order data. What is first order data? Each of these qualitative studies will report the participants' perceptions. Say, for example, our study is to find out participants' perceptions about malaria. So each of the participants would have shared their own thought process about what they think malaria is and how do they intend to see in case they get affected by malaria, what will their healthcare seeking pattern be, and how does it affect their own job, how does it affect their lifestyle. All this will be quoted as individual quotations in the study. So these direct quotations directly, whatever the participant says in the study is called as first order data. The second order data is nothing but when multiple participants give different opinions about malaria, the study author of the individual participant study might consolidate it into a few paragraphs, and which is called as the author's interpretation of the first order data. Then this is called as the second order data. And third order data is nothing but when we do a qualitative evidence synthesis, how we utilize data from this first order and second order data and make our own synthesis. So an ideal qualitative evidence synthesis should take into account both first order data, which is nothing but the participants' direct perceptions, and also should take into account the author's interpretation of the first order data in the each of these primary studies, which are used in the qualitative evidence synthesis. So how do we collect data in individual qualitative studies? If we do a quantitative study, we can do multiple lab tests, multiple anthropometric data. All this can be done to for data collection. Whereas in qualitative studies, it is more in terms of getting the participants' perspectives. So here we can collect participants' data in using methods like interviews, focus groups, observation, document analysis, and something called as ethnography. So each of it has its own advantages and disadvantages. The most common method of data collection in qualitative studies is by means of interviews. Interviews can be either structured interviews, semi-structured, or unstructured interviews. Unstructured interviews means there is no clear-cut pre-framed questions in per se, whereas in structured interviews, there are clear-cut pre-framed questions before the questions are put forward to the participants. So advantages of interviews that we get rich amount of data and it allows probing, whereas disadvantages include that it is time consuming and there is a possibility of interviewer bias. And the second method of data collection is called as focus groups, wherein the population under study are organized into groups of like 6 to 10 each, and we there is one moderator who gathers information from this group and puts it into the primary study. The problems with this focus groups is that one or two people in the community might be dominating the opinion of the entire group, and it cannot be used for sensitive topics because it is a group discussion. And third thing is something called as observation, wherein we do not ask the participant per se about their perspectives. Rather than that, we intend to observe the participant in their own natural settings. So problems with observation is that there is a possibility of Hawthorne effect, which means that when a participant of the study knows that he is being observed, there's a possibility of him modifying his or her own behaviors. Like say, for example, if in our previous example, we had seen what is a KAP of following lifestyle in participants with cardiovascular disease. If the participant knows that his behavior is being observed, he'll be more likely to be more compliant to lifestyle intervention, and this can be contributing to a bias. And fourth and fifth methods include document analysis, wherein we'll analyze pre-existing documents and to synthesize data. And fifth one is ethnography. Ethnography is where the research author will directly try to be a part of the immersive community and try to become a part of the community per se and find out qualitative data from the population. And it helps to give a deep contextual understanding about the phenomenon of interest. So once we have extracted data and from each of this individual study, the next step is to synthesize this data. And there are multiple methods by which these data can be synthesized for final analysis. Some example methods of data synthesis can be in the form of aggregative in nature or configurative in nature. And some examples for methodology for synthesis methods include grounded theory model, thematic synthesis, narrative synthesis, and framework synthesis. Grounded theory model is nothing but a scenario where we don't have any preformed hypothesis available, and we directly take into account multiple participants' individual account about the event, individual perceptions about the event, and we intend to generate our own hypothesis about the topic of interest. Whereas in thematic framework synthesis, even prior to beginning the study, we have our own pre-existing framework. Say, for example, if our study intends to find out why participants are not seeking healthcare for malaria, we can put across multiple themes, like one might be under cost, one might be under non-availability of healthcare, one might be under distance to healthcare. So we have a pre-existing framework, and then we analyze the study, and the perceptions from individual studies are put into multiple different frameworks that we have already selected before proceeding with the study. Narrative synthesis is nothing but the data from the primary studies are aggregated together without any preformed framework. And in thematic synthesis, here we do not have a pre-existing framework decided, but once we have collected data from multiple primary studies, we organize it into multiple different new themes of interest. So synthesis can be either configurative or aggregative. We tell it to be more configurative when the findings are supposed to be useful for generating a new hypothesis. We use an aggregative synthetic model when our plan is to mainly to test a pre-existing hypothesis. And once we have finished data synthesis, the last step would be to analyze our confidence in the findings of the systematic review, for which one tool which we can use is the Great Cerqual checklist. The Great Cerqual checklist helps us assess the confidence of findings in a systematic review under 4 different methodologies, which include assessing the methodological limitation of the individual studies, assessing coherence, assessing the relevance of data, and fourth would be the assessment of the adequacy of the data. So some limitations of qualitative research includes it is a very time-consuming process. It is more researcher skill dependent. It is not easily generalizable because only a small sample size is usually evaluated, and there is a high risk of bias because interpretations tends to be subjective. So next we'll be coming across we'll be doing the systematic review, and we'll be doing critical appraisal of the systematic review. Before we go into the Great Cerqual checklist, I would like to put across a case scenario wherein a junior doctor is doing a bond in Northeast Assam, and he notices that many patients who come to his hospital have been having so much delay in seeking healthcare for malaria. And before coming to seeking appropriate healthcare, they have been relying on traditional remedies, and they have been relying on multiple traditional healers, and they have many of them have stopped treatment early, leading to many of them developing severe malaria. So he comes across one qualitative systematic review from Colombia on perceptions of malaria, published in 2020. So can insights from the study help improve malaria care seeking behavior in this setting? So for this, I'll be assessing the Great Cerqual checklist on the systematic review of qualitative studies done about malaria in Colombia. It was published in the year May 2020 in Science Direct. So what is Great Cerqual? Great Cerqual is an approach for assessing how much confidence that we can place in the findings from a qualitative evidence synthesis. The overall assessment, we start off by giving a high confidence in the assessment, and once we serially assess the findings from the study and comparing, we can downgrade it to moderate, low, or very low based on the subsequent findings. And under Great Cerqual, we assess a study under 4 different domains. One is to assessment of the methodological limitation of the individual studies. Second is to assess the coherence of data. Third is to assess the adequacy of data. And fourth is to assess the relevance of data. Methodological limitations include assessing the concerns about the design and conduct of the individual contributing studies in the qualitative evidence synthesis. And coherence involves finding out how well is the review finding supported by data from the contributing studies. Adequacy involves overall determination of the richness and the quantity of data which supports the finding of the qualitative evidence synthesis. And relevance involves assessing the extent to which the evidence body is applicable to the context of the review question. So these are all the 4 components of the Great Cerqual checklist. So first component, we'll be doing the methodological limitations of the individual primary studies included in the qualitative evidence synthesis. So in this qualitative evidence synthesis, the authors have finally utilized about 10 studies in the qualitative evidence synthesis, and we'll be doing a methodological analysis of these 10 studies. So these are all the 10 studies which were included in the qualitative evidence synthesis on malaria. And out of which, when we tried to access these articles, we couldn't access 5 of these articles, and the links provided did not help us find out the individual articles per se. 2 of these articles were given in Spanish, for which we used Google Translate to translated to English so that we can assess the methodology. And the rest of the 3 studies were given in English. So ideally, the authors are supposed to do a methodological analysis of each of these studies and for each of the findings that they synthesized from each of these primary studies, but they have not provided an individual methodological analysis, but they have only provided a summary of the methodological limitations of all the studies together per se. So we'll be doing our own methodological analysis of individual studies included here using a tool called as a Camelot tool. This Camelot tool has been recommended by Cochrane for assessing the quality of an individual qualitative study. So the Camelot tool assesses the individual qualitative study in terms of research aim and question, in terms of stakeholders involved, in terms of researchers involved, in terms of context of the research question. And under research aims and question, we'll be assessing the research strategy, theory, the ethical considerations, equity, diversity, inclusion consideration. And in terms of research conduct, we'll be seeing the participant recruitment process, the data collection process, how they analyzed and interpreted the data, and how they presented the data. So the first and second studies, we could not access the individual studies per se. The study 3 was to assess the third study included in the qualitative evidence synthesis was on evaluation of the malaria control program in Colombian Amazon done by Franci Pineda. Applying the Camelot tool, the research question used in the study was to evaluate the malaria control program in the Colombian Amazon department. The stakeholders involved were the local communities and indigenous population and the local health ministry. The context chosen was certain municipalities in Colombia which had very high malaria prevalence. The research strategy they intended to use was an evaluative study design, and they had used predefined evaluation categories like policies, decentralization, local health plans. They have not explicitly stated ethical considerations. And how did they ensure equity? They have chosen very high vulnerable population who are at high risk of malaria in this study. And they have not explicitly stated anything about inclusion, and they've used the grounded theory model to give a summary of the findings. They analyzed the data using literal transcription. They collected data using semi-structured interviews, and the presentation was thematically organized under human resources, intersectoral action, capacity and coordination for diagnosis, and affiliation to the local healthcare program for control of malaria. The second study which we did a methodological analysis was about the perceptions, attitudes, and practices regarding malaria in the Colombian Amazon. Here, the research question was the perception, attitudes, and practices about malaria in the Colombian Amazon. Stakeholders involved were the indigenous communities in Colombian Amazon and the malaria's rollback malaria program. The research strategy they used here was not as interviews, but as focus groups. They ensured equity by including both the people at high risk of malaria like loggers and low risk of malaria like housewives. And they ensured diversity by including both indigenous and the mestizo population here. And here, how did they make sure the study was inclusive? The lead researcher here solely acted as an observer and moderator, did not directly involve in the data collection. The participant recruitment, they had used a total of 23 focus groups. Data was collected in terms of audio recordings and analyzed by transcripting these audio recordings, and the presentations were thematically organized into etiology, preventive measures, diagnosis and treatment, and community participation for malaria. The third study which we could assess was a study called as the World of Malaria and Health Education Experience in the Colombian Pacific Coast. Here the research question was about the design, validation, and implementation of community health education material called the World of Malaria. And it was done in the communities of Buenaventura in Colombia. The context here was finding out whether giving the participants certain community health education material can improve healthcare seeking for malaria. They used a model called as the proceed model and the research action participation model. And they ensured diversity by including all the cultural and ethnic groups in Colombia. Participants were recruited by convenient sampling, and what they did was the research team brought together the entire community, and they made the community itself generate materials, games that can help in improving healthcare seeking for malaria. They presented their findings by describing each of these education materials that were created and what were the achievements in terms of strategy and number of trained leaders and number of insecticide treated bed nets that were distributed. The fourth study that we did a methodological analysis was this is the study on patterns of treatment for childhood malaria among caregivers and healthcare providers in Colombia. Here, the research question was to understand how caregivers provide treatment to children under 11 years for malaria and to assess the role of different healthcare providers in treating febrile illnesses in children. The stakeholders involved were the caregivers and the children under the age of 11. And the research strategy employed a technique called as illness narratives. They ensured diversity by including both the healthcare providers and the caregivers and the mothers who are the who intend to give healthcare to the child. The theories they used was the medical anthropology framework, and here a total of 67 caregivers and 15 healthcare providers were interviewed using semi-structured interviews. The findings were described in terms of healthcare seeking patterns, how they recognize the signs, how they got treated for the fever, and what are all the factors that determined their healthcare seeking behavior, which included the availability of drugs, healthcare provider quality, the distance of accessing healthcare, the costs involved to access healthcare. The last study that we'll be doing a methodological analysis is the study 8, which assessed the malaria situation in the triple border region of Brazil, Colombia, and Peru. Here, the research strategy they employed was the SWOT technique, which stands for strengths, weakness, opportunities, and threats. And they used the phenomenon called as illness narratives to find out how is the malaria situation in the triple border and what are all the barriers to access healthcare in the border regions of Brazil, Colombia, and Peru. It worked on a socio-geographical framework, and they conducted a total of 47 semi-structured interviews, and they provided the data in terms of the SWOT, and they gave findings in terms of how exactly to improve malaria surveillance and malaria treatment in these border regions. These 4 studies we could not access, so we could not do a methodological analysis for these studies. So to give rating to the methodological analysis of each of these individual studies, there are multiple standards. The authors of this study have used a standard called as the SRQR standard, which stands for Standards for Reporting Qualitative Research. And overall, considering all the 10 studies, there were multiple methodological issues. Say, for example, 4 of the studies did not give a clear-cut research question or purpose of the study. There were no clear qualitative approach stated in 6 of the 10 studies. 5 of the studies did not give a clear-cut sampling strategy as to how they recruited the study participants. And 4 of the studies did not explain the ethical issues related to involving human subjects in the study. 6 of the studies did not give data towards links to the empirical data. 9 of the studies did not report conflicts of interest, and 7 of the studies did not clearly mention what was the source of funding of the study. So the top 3 studies which complied to the SRQR checklist were this study by Casas, Polanco, and Rincon, which had 83, 79, and 75% compliance to the SRQR checklist. Only 4 studies had described their approach, and overall assessment for the methodology. After seeing all this, I have given a moderate consensus for the methodology of the individual primary studies included in the qualitative evidence synthesis. The second component that we'll be assessing is the coherence of the study, which means how well does the data support the underlying review finding. So what are the steps to assess coherence? First is to collect information, which is nothing but finding out what are all the relevant data in the review finding, which has been made from the underlying individual studies. The second step would be to assess coherence concerns, wherein we'll be looking at whether the data was coherent to the underlying primary studies or whether there were contradictions when compared to the underlying primary studies, and whether they were ambiguous to the underlying primary studies, and whether there could be possible alternative explanations for the findings of the systematic review when examined. And step 3 will be we'll be judging the seriousness in terms of coherence, and we'll be giving an overall judgment as either no concerns, minor concerns, moderate concerns, or major concerns. The threats to coherence can be in the form of giving contradictory data in terms of ambiguous data, or in terms of having plausible alternative explanations or interpretations for the findings. So how do we assess coherence? Again, when do we say we are less confident? We say we are less confident if some of the data supporting the qualitative evidence synthesis findings is contradictory to the underlying primary studies, and if some of the data is ambiguous to the underlying primary studies. So there's a spectrum through which there is a transformation of data when it is put into a qualitative evidence synthesis. The authors may decide to do just a descriptive finding wherein they put across only directly the findings from the underlying primary studies, or they can use something called as interpretive explanation, wherein they give their own explanatory findings for the studies from the facts that are found out from the underlying primary studies. So before we can do a coherence assessment, I would like to show the 5 themes under which the qualitative evidence synthesis was done. In this systematic review, the findings of the study have been organized under 5 different themes. The first one was health disease process, wherein the authors assessed what is the generalized perception of the participants in terms of health and in terms of disease. The second step was to find out the structural and social determinants of malaria, wherein they found out the participants' perceptions about origin of malaria and how does the participants and the family's life and the work condition affect their how does malaria affect the participants' life and work condition, and what are all the ecological disruption that can contribute to malaria. And the third theme under which they analyzed the study was to assess the individual's wisdoms and insights about malaria, under which they found out how well they recognize the symptoms of malaria, how was the awareness about mosquito in the local community, and whether there was secularization of biomedical language in the local community. The fourth theme was to assess the effects and medical attention. And under this, they assessed what are all the biological, social, and emotional consequences of having malaria. And they also intended to assess the doctor-patient relationship once a patient develops malaria. The fifth step was to find out appropriate interventions and elimination strategies for preventing malaria, and what are all the things that can be done at the community level, and the things that can be done at the institutional level, and things that can be done at the policy and government level to prevent malaria. So this is the same thing. These are the themes under which the study data was presented as, in terms of structural social determinants of malaria, subjects' wisdom and interpretations, the need for medical attention and the healthcare seeking behavior of the participants who developed malaria, and the interventions that can be done for elimination of malaria. So the first step would be to collect and consider the necessary information related to coherence. The first step would be to assess, import theories from the existing literature, and we find out whether the findings from the study are original explanations or interpretation made by the study author per se, or whether they are directly from the underlying primary studies used in the analysis. And ideally, before assessing coherence, the authors are supposed to give a summary of findings from each of the themes that they've analyzed and see whether they are coherent to the underlying primary studies that they have taken the data from. Whereas in our study, the study authors have not clearly given a particular theme or a particular summary of finding from under each of the particular theme. So we have taken some important findings under each of the themes of this qualitative evidence synthesis, and we'll be trying to see whether they were coherent with the underlying primary studies. So in terms of the generalized health disease process, the authors described that the participants described health as a state of happiness, body treasure, ability to perform daily activities, and they described disease as a disruption with nature, an autonomous entity, or an alarm or related to hunger. And in terms of structural and social determinants, the study authors are determined that knowledge about malaria is not put into practice because there is lack of time, lack of interest in the community, and there is a lack of community organization. And in terms of individual wisdom and insights regarding malaria, the participants' perception was that mosquito is one of the primary causes of malaria, and it is associated with the subject's presence in regions of hot climate, high humidity, and wet weather. Other themes that they described in terms of consequences of the disease and need to find medical attention was that when a patient develops malaria at the emotional level, they develop fear and apathy towards life. And patient experience different stage of illness, which includes starting from the stage of acceptance to the stage of resignation, wherein they place themselves completely in the doctor's hands. And the fifth theme for interventions and prevention of control, the primary authors of this qualitative evidence synthesis have suggested a requirement of intersector and citizen participation, control of illicit drug trafficking and herbal medicines for treatment of malaria. And they've identified availability of diagnostic networks, specialized physicians and resources are required for the control of malaria. So were there any, these are all findings of the study which were directly taken from the underlying primary studies. Were there any theories that were developed as original explanation? Yes, there were two theories which were developed as original explanation. One is called as a secularization theory. The study authors have noted that though there were multiple different studies assessing people's perceptions of malaria, their knowledge about malaria remained same irrespective of where they were from and their education status per se. And how they intended to explain this phenomenon wherein most of the participants had a similar understanding about malaria by using the term called as secularization. And which means that the result of the thing that they different communities have the same understanding about malaria is because of deep historical penetration of the biomedical discourse into the community, because there was good penetration of government eradication programs and life experience with the disease into multiple different communities in Colombia. And they have also they have also used a terminology called a social convergence, wherein they explain that communities view the disease similarly because they share the exact same structural realities, because most of them were in poverty and they were having similar working conditions and they had similar interactions with the fragmented healthcare systems available in Colombia. So these are all phenomenology not described by the underlying primary studies. So assessing the threats to coherence, in the first there were some contradictions in the qualitative evidence synthesis that we found. One finding from the systematic review was that they had reported that there was no significant difference among multiple different groups that they analyzed about knowledge of malaria symptoms and origins. Whereas when we analyzed the primary studies, we found out that there were certain local non-indigenous populations who had a low level of information about the knowledge and information about malaria, and they lacked the perception of malaria as a relevant health problem. But they ignored this finding and they summarized, because most of the primary studies had stated there was no significant differences. They took that into account and they did not take into account the fact that there were certain populations who had very low understanding about malaria. And they also stated that the Colombian population share a unified understanding of malaria because of social convergences, because they have similar poverty levels and similar work conditions and similar healthcare seeking behavior. Whereas when we looked at the underlying primary studies, we noticed that there was an absence of qualitative studies on uh, occupations who are at high risk of malaria, which included miners and people who are practicing agriculture. And because this crucial data is missing, we have stated this finding as to be contradictory to the underlying primary study. And there were some ambiguous data as well. Like, for example, under the theme of individual wisdom and insights regarding malaria, they had stated that representations about the disease come from contact with both conventional medicine and Western medicine. And there was no clear-cut source as to where they came to this conclusion. And under the theme of interventions for disease prevention and control, they had stated that many of the participants had resorted to herbal medicine, beverages, or baths, or fumigation of residences to prevent malaria. And some communities felt that it is not possible to entirely kill all the mosquitoes for malaria prevention. But there was no clear-cut source given as to wherein they found this data from. And were there any competing theories? Whether there are plausible alternative descriptions to the study findings? There were two places where we found competing theories. Like, for example, to explain why why different ethnic groups had the same knowledge about malaria, they generated a theory called a secularization. But this per se uh, may not be the actual thing, because most of the systematic review, the primary studies included data from only relatively static and accessible population for researchers. They did not take into account the population at risk like miners or participants who are practicing agriculture, and those participants who are at areas of conflict wherein the study authors did not have access to. So this was a competing theory that we found here. So overall, with regards to the concerns regarding coherence, we have given a moderate concern for coherence here. The third component that we'll be assessing here will be the adequacy of data, wherein we'll be intending to find out whether the findings of the qualitative evidence synthesis is supported by underlying rich study and adequate quantity of primary studies. So adequacy depends on the degree of richness and quantity of data which supports an underlying review finding. We give a less confidence for adequacy of data if the data underlying a review finding is not sufficiently rich, or if it comes from only a small number of studies or small number of participants. So the steps to assess adequacy involves collecting the necessary information, assessing the body of data that contributes to each of the review finding, and making a judgment about the seriousness of concerns with regards to adequacy. So in a qualitative evidence synthesis, if our finding is more of a descriptive study, there is only a few lesser demand for data richness. Whereas if our study is going to be more explanatory, it is necessary that our data is supported by underlying rich studies. And in cases of descriptive studies, where there is a broader scope, there is a demand that there should be the findings of the study should be supported adequately by data quantity. And if our qualitative evidence synthesis is planned to be very explanatory and having a broader scope, it should be adequately supported by rich studies and high number of underlying sample size or data quantity. So what is data richness, what is data adequacy, and what is data quantity, and what is data saturation? These are all terms used to assess adequacy of the qualitative evidence synthesis. And what do these terms mean? Data richness, it means the extent to which the information provided is detailed enough to allow the review author to interpret the meaning or context of what is being researched. And what is data adequacy? What is data quantity? Data quantity is nothing but the number of studies and participants from which the data of the qualitative evidence synthesis comes from. And what is data adequacy? It is the overall determination of a study's data richness as well as data quantity put together. And what is data saturation? Data saturation is the peak of adequacy, wherein we have reached a point in data collection where even on further analysis and even on getting data from newer participants, we do not find out any new findings, concepts, or themes. And that we have already reached completed most of our data collection. So again, recollecting the fact that we had 5 different themes about malaria in this qualitative evidence synthesis. The authors per se have not they have not summarized the findings from each of these themes, and they have not specifically assessed the adequacy of each of these findings. So we'll be taking some important findings under each of these themes, and we'll be seeing whether the data was adequate or not. For the first theme about generalized health disease process, the authors have stated that there's a need to combine traditional and modern medical care to improve healthcare seeking for malaria. And health is being viewed as well-being, function, or divine gift, and disease is seen as disruption, warning, or imbalance with nature. Sorry for the mistake, it's data quantity. This data has been supported only by 3 studies involving only 68 participants. And we could not address data richness because they were taken from the first and second studies. Most of this data was taken from the first and second studies for which we did not have access to. So we are given a moderate concern for the data adequacy here. For the second theme on structural or social determinants of malaria, their main finding was that malaria is understood as a complex interaction between social, cultural, political, and ecological factors. And it is strongly influenced by socioeconomic conditions like mining and agriculture, wherein the participants have high exposure to malaria and poor working condition and proximity to vector-borne environments. And the third finding was that home and family context play a key role in shaping the initial response to malaria. So whether was it supported by adequate data quantity? Here, these data stem from 4 different studies from across 118 participants, which seems more or less adequate. Whereas in terms of data richness, there is a lack of data of each of these studies from miners and agriculture workers who are all at high risk of contracting malaria. Whereas they have given a generalized finding that minus or at high risk without being supported by underlying primary study. So here again, we have given a moderate concern for data adequacy. So the third theme being individual wisdom and insights regarding malaria. The study authors have stated that the traditional healers and caregivers are now combining both cultural practices and modern medical concepts for treating malaria. And there's a concept of secularization wherein government and healthcare programs have integrated scientific concepts into local language and understanding, and they have reshaped how the communities perceive, explain, and manage malaria. And though we have lots of knowledge about malaria, it has not been put into practice because of lack of time, interest, and community organization. So this data has been supported by 6 studies in over 300 participants, and which seems adequate. But in terms of data richness, it includes both new complex explanatory findings called as a theory of secularization, and they've also included certain descriptive findings like local names for disease and symptom recognition. So it seems to be supported by underlying rich data. Hence, we have given a low concern for data adequacy under the theme of individual wisdom and insights about malaria. For the fourth theme on effects and consequences of disease and need to find medical attention in health services, the study authors have stated that the disease and the risk of contracting malaria has resulted in physical disability. It has caused emotional distress in the population, and it also causes social disruption, affects work, family life, and even leads to migration of participants to different areas where there's a lesser malaria risk. And with regards to the experience of malaria, the participants pass through different stages of malaria, like from early symptoms to the stage of acceptance and to the stage of resignation, wherein in advanced disease, they place themselves in the doctor's hands. And the study authors also point to an unequal doctor-patient relationship, and there's a delay in the participant seeking healthcare. And they have also stated that the healthcare seeking behavior is strongly influenced by the access to services, cost, distance to seeking healthcare services, and the quality of healthcare available. And because there are barriers to seek healthcare, many of them resort to home remedies and self-medication, which results in delay in seeking healthcare for malaria. So in terms of data quantity, this data has been supported by 6 studies involving over 350 participants. Hence, we feel here the data quantity was adequate. But in terms of data richness, they've described detailed illness narratives and focus group discussions among 350 participants. Hence, we feel the data is sufficiently rich, and hence for this theme, we are given a no concern for in terms of data adequacy. And coming to the last theme about interventions for disease prevention and control, the study authors have stated that preventive practices can include herbal remedies, fumigation, mosquito nets, and at the community level, it requires motivation, and community motivation and knowledge per se is not enough. And at the institutional level, there are problems like poor accessibility, limited resources, and weak coordination that hinder effective malaria control. So this data also been adequately supported by good number of studies. They have included 8 studies with over 400 participants for generating this data. And in terms of data richness, only one of the studies had actually assessed if preventive practices like giving educational materials to the participants can bring down malaria incidence. But here the authors have suggested other methods like herbal remedies, fumigation, mosquito nets, which are all not described in the underlying primary studies. Hence, here in terms of data adequacy, we are given moderate concerns for data adequacy. So coming to the last component of relevance, does the evidence apply to the review context? So when do we say the qualitative evidence synthesis is relevant? We say relevant, the extent to which the body of data from the primary study supports a review finding is applicable to the context specified in the review question is what relevance means. We say there are concerns about relevance if the context of the primary studies underlying a review finding are substantially different from the context of the review question. So how do we assess relevance? First, we clarify the review questions and the context of the review question. We decide the appropriateness and the implication of the sampling strategy. The third step is to gather information about relevance in the included studies. The fourth step would be to assess the body of data that contributes to each of the review finding. And finally, we make a judgment about the relevance, and we give our own level of concern here. So first step is to clarify the review question and context. Going back to the SPICE protocol, applying it to our systematic review, the setting that was chosen here was the areas which were endemic for malaria in Colombia. And these were areas characterized by hot climates, high humidity, and proximity to rivers. And most of the underlying primary studies were heavily concentrated in departments of Antioquia and Amazonas in Colombia. And P stands for perspective here, and whose experience were being explored. They intended to explore the perspectives of different stakeholders, which included infected patients, their caregivers, highly vulnerable population, which included Afro-Colombians, mestizo farmers, and informal miners, the child caregivers, traditional healers. They also wanted to assess the adequacy of healthcare programs, and hence they had planned to understand the perspectives of healthcare personnel and program administrators as well. And what was the phenomenon of interest here? Phenomenon of interest was about the general aspects of health and disease in the population, and finding out what are all the structural and social determinants of malaria, what were the individual wisdoms and insights about malaria in the subjects, and what were the effects of contracting malaria and effects of consequences of disease, and what are the healthcare seeking behavior for malaria, and what are all the interventions available for disease prevention and control. Comparison per se, the study did not have a direct comparison in the large scale, but within the study, they intended to analyze the traditional beliefs versus the biomedical understanding of malaria. And they also have given data about using home remedies and seeking formal healthcare for malaria. And evaluation per se, the study per se does not clearly state as to what exactly was their purpose of doing the study and what exactly was the primary outcome that they intended to find the study. Hence, we have found out multiple different evaluation parameters that the study intended to find. And step 2 is to decide on the appropriateness and implications of the study inclusion strategy. How did the qualitative evidence synthesis decide on the 10 primary studies? So what was a search terminology? For the disease per se, they used terminologies of malaria, plasmodium, and paludism, which is the local terminology used for malaria. And for finding out qualitative research on the topics, they used multiple different synonyms for qualitative research. Here, I'd like to emphasize the fact that when we do quantitative research, we do not have a necessity to include multiple different search terms because they are all self-explanatory. Whereas in terms of qualitative research, they come under multiple different terminology. So using just a single terminology might not lead us to finding out all the available qualitative evidence under the particular topic. Some terminologies like black water fever and other alternative descriptions for malaria were not included in the search terminology here. And where all did they look for sources? They utilized major scientific databases like PubMed, Embase, Cochrane Library, Silo, Happy, and Redalyc. They also searched in Web of Science. They also looked at multiple local universities available in Colombia, like the University of Antioquia, University of Los Andes, and University of Colombia, to find out relevant primary studies on this topic. So this is one example of the mesh terminology that they had used in PubMed to find out the relevant studies. So the inclusion criteria required that the central subject of research be on malaria, and it had to be an original qualitative study, and it should have been conducted in Colombia, and it could have been conducted anytime before August 31, 2019. They had excluded other studies which had intended to analyze quantitative studies, like, for example, clinical studies, mixed method designs, and other duplicate records were all excluded from the study inclusion criteria. So this is the Prisma diagram of the systematic review. And overall, the study authors had screened about 150,000 articles, and after applying the inclusion and exclusion criteria, they had come up with about 429 records. And they had excluded some studies because they were not of the relevant topic, they were not original, or because they were done in other countries. And finally, they assessed about 149 articles with the full text for eligibility. And after excluding studies which were quantitative in nature or clinical in nature, in the qualitative study, they had included a total of 10 primary studies. So again, just emphasizing, these are all the 10 different studies that were included in the qualitative evidence synthesis. So whether it was appropriate to have used this inclusion strategy, the study utilized a comprehensive inclusion strategy, and they had used multiple broad terms to capture most of the studies. But though they had applied broad terms, most of their studies were highly skewed, and most of the study data had come from primary studies done in only two regions, which was Antioquia and Amazonas. And the authors also have acknowledged that there could have been a possible failure to capture some studies because they might have not had standard editorial structures like clear-cut abstracts or standard terms for qualitative studies here. And there is also a possibility of publication bias because they had not appropriately searched for data on, there are not appropriate, they did not find out adequate studies on conflict zones, illegal miners who are all at high risk for contracting malaria. And because they had utilized search for studies only in English and Spanish, there's a possibility of language bias as well. The study was also not registered in Prospero before undertaking the systematic review. So next step would be to gather information about relevance of the findings of the study. So again, reiterating the themes of the study, the first being the generalized health, understanding about health and disease process in the community, finding out the structural and social determinants of malaria, understanding the subject's wisdom and interpretation about malaria, understanding the participants' health-seeking behavior, the consequences of risk of disease and consequences of having malaria, and the interventions for preventing malaria. So how do we assess relevance? We tell finding of the systematic review to be relevant if it matches the underlying primary studies population characteristic, the setting and place, the time period. The intervention is also matching between them same, and it has a similar policy and it has a similar phenomenon of interest as compared to the underlying primary study. So again, I'll be putting because the study did not summarize the findings under each of these themes, we'll be identifying the main data from each of these themes, and we'll be seeing whether they were relevant or not. So coming to the first theme about generalized aspects about health and disease, the context of the review states that there's a need to combine traditional and modern medical healthcare to improve malaria healthcare seeking behavior and prevention. The context of the primary study was taken from studies first and two, but we could not assess relevance because we were not able to access the underlying primary studies. And again, health, we also saw the description of health and disease by the community. And here also, again, it was taken from studies 1 and 2 for which we did not have access. And hence we are given an unclear relevance to the findings of this study under general aspects of health and disease. And coming to the theme of structural and social determinants of malaria, two of the findings had an unclear relevance, and one finding like stating that work at geographical locations with a difficult access and being often located next to main rivers of the country, like practicing agriculture, practicing mining, had put the participants at a high risk of malaria. And it was adequately supported by an underlying primary study, and hence we had given a direct relevance. Similarly, for other findings on different themes like individual wisdoms and insights of malaria, we had given different relevance like unclear, direct, and indirect relevance for each of the findings. And in terms of effects and consequences of malaria, we had again given an unclear relevance to the findings of the systematic review. And with regards to interventions for disease prevention and control, again, they had stated that there was a strong need to develop educational materials for prevention of malaria, which was supported by a study, which is the fifth study, which analyzed what happens if we give educational materials to the population for prevention of malaria. Hence, here we are given a direct relevance. Whereas for other findings like other control measures, it was not adequately supported by underlying primary studies. Hence, we are given partial relevance to the same. So overall, if you had to assess relevance in total, we are given a moderate consensus for relevance. So if you had to put across all these four different aspects of Great Cerqual checklist, and we had to give a overall Cerqual assessment for the summary of give a summary of confidence in the themes of the qualitative evidence synthesis, because there were so many places where we had to give moderate concerns, I have given a low confidence in the evidence from this study. So coming back to our primary question, can insight from this Columbia study help in Assam or India? I would like to conclude by saying, I would say at this present point, I would say no, because there were many places wherein we had moderate concerns with regards to methodology, with regards to adequacy, and with regards to relevance. And our context might be slightly different from their local context, though things like poverty, work, and illness experience and healthcare seeking patterns might be slightly similar. So what we would be requiring is to do another hypothesis and do another study in our own local setup to find out what are all the factors by which we can improve healthcare seeking behavior in our own local setting. So I'd like to thank Dr. Tambu, Dr. Vignesh, and Dr. Tina ma'am for helping me with the presentation. Thank you.